Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. Please make sure you're not behind a firewall, as this will prevent you from viewing the presentation. Our moderator, as well as speaker for today, is Isik Su. Dr. Su is currently consultant in respiratory and ventilation medicine, Lane Fox Respiratory Service, Guy's and St. Thomas's NHS Foundation Trust, London. He is honorary senior lecturer, Faculty of Medicine, King's College, London. Dr. Su has published several articles and abstracts in peer-reviewed journals on topics relating to non-invasive ventilation on COPD. He is a co-author and co-researcher on several studies on these topics with Professor Hart. Welcome.
Thank you, Monica, for that very kind introduction. The title of today's webinar is Home Non-Invasive Ventilation and COPD, Who, When, How and Why. And speaking today on this very timely topic is an expert, a friend, a mentor and colleague, Professor Nicholas Hart. He is Deputy Medical Director of the Heart Lung Critical Care Clinical Group at Guy's and St Thomas's NHS Foundation Trust in London, UK. He's Professor of Respiratory and Critical Care Medicine in the Faculty of Life Sciences and Medicine at King's College London. He established the Lane Fox Clinical Respiratory Physiology Research Centre in 2007 with a research programme focused on readmission prevention in acute exacerbations of COPD, and also around clinical trials to improve long-term outcomes in sleep-disordered breathing and chronic respiratory failure. Now, without further ado, I'd hand over to Nick. I beg your pardon. So I need to go through some disclosures, and our speaker, Professor Hart, has to disclose the following relationships: grants and research support to his institution, and consultations for Philips, for ResMed, Bishop Akel, B&D Electromedical, and Brias Medical. I'd like to remind you that this educational activity is approved for 1 contact hour for nurses and respiratory therapists, and a link to obtain credit will be available at the end of the webinar. Support for this educational activity is provided by Philips. And now, without further delay, I'll hand you over to Professor Hart for this interesting talk.
Thank you, Isik, and thank you to all the team behind and the Sachs team for pulling this together. This is a really timely topic. It really highlights where we're going to go back to in terms of we've moved out of a significant proportion of our life being focused around COVID, and now it's time for us to get back to COPD. And what I want to talk about is home non-invasive ventilation in COPD, who, when, how and why. And these are really important topics. And the data that I'm going to present actually answers all of these questions, and really importantly answers these questions in the stable COPD patient with chronic respiratory failure, and those patients who are post-exacerbation with persistent hypercapnic respiratory failure. So there's 4 learning objectives based on what I've just said. We're going to discuss who we should target for home non-invasive ventilation treatment for our COPD patients. We're going to target or focus on when we should start the home non-invasive ventilation. We should discuss how we're going to do it, and then why we're going to do it. We need to be able to relate to the patient about why we should proceed with using non-invasive ventilation in patients with COPD and chronic respiratory failure. I'd really highlight as you have heard from Dr. Sue, which is our non-invasive ventilation clinical trials group, which has got unrestricted funds from a number of industry collaborators and partnerships. In particular, I'd like to highlight Dr. Patrick Murphy, who's clinical lead at the Lane Fox unit here in London, and he's led on a number of the studies that I'm going to discuss in the next 30 to 40 minutes. So patient selection, who are the patients that we're actually going to target for home non-invasive ventilation? And let's first of all look at those patients with chronic stable COPD. We're going to consider the evidence currently available to us for using non-invasive ventilation in stable COPD, and I want you to focus on the PICO. And as we know, this is the approach we use in randomized controlled trials. So it's the target population, it's the intervention, it's the comparator group, and the outcome, the primary outcome of the study. So this is a study that was published back in 2014 by Thomas Kernlein and colleagues from Germany. This was a randomized controlled trial. They targeted patients with severe COPD and stable chronic respiratory failure. And the patients were actually recruited who had a mean PaCO2, partial pressure of carbon dioxide, of 58 millimeters of mercury. So these were significantly hypercapnic COPD patients. And when you look at the baseline demographics of the group, it's really obvious that these patients had severe obstructive lung disease. They were hypoxic and also hypercapnic. Now, interestingly enough, their 6-minute walking distance was relatively well preserved. And the importance of looking at this baseline data is to show that it was matched in each group in terms of the control group and the intervention group receiving non-invasive positive pressure ventilation. But I just want to highlight there the 6-minute walking distance as a marker of exercise capacity was, for this type of patient, relatively well preserved. Now, there was another important point to this type of patient that they recruited into this study in Germany, is they had a low admission rate. And that, again, we need to take into account of the kind of phenotype of COPD patient that is likely to benefit from home mechanical ventilation in patients with chronic stable COPD. So we've got severe stable patients with a low FEV1, less than 1,000 mils or less than a litre. They've got a high CO2 with a PaCO2 greater than 52 millimeters of mercury, a relatively preserved exercise tolerance, and a low annual emergency admission rate. So the study was designed that there will be standard COPD treatment and home NIV in addition to the LTOT. So you've got standard treatment plus home NIV and LTOT. In the comparator group, the patients received LTOT. Now, this was a study where they targeted CO2 reduction. It was one of the first studies which we really focused on. Folk who know the field will be aware of the data that has come from a number of the previous studies. And if I talk about the AVCAL study that Doug McAvoy left from Australia, the criticism or the comment about that study of not showing a benefit was they didn't target CO2 and the IPAP levels were too low to actually result in benefit. So the importance of targeting CO2 within this study is really, really important. And this is answer the question of how. I want to make sure that I'm getting a 20% reduction in the CO2 or driving the CO2 less than 6.5 kilopascals or about 55 millimeters of mercury in terms of the PaCO2. So with this targeted CO2 reduction, what the teams sought to achieve was to see if there was any difference compared to standard treatment with LTOT therapy. And important to that, with their primary outcome, they used all-cause mortality. And what they observed was a significant difference in all-cause mortality at 12 months. And so when you're talking to a patient of why you may want to take this treatment, we can significantly reduce your mortality. And you see there's a mortality in the standard group, the control arm of 33%, and in the treatment arm of 12%. And so a significant difference in terms of the mortality between the two groups. Now, it's important to look at the Kaplan-Meier curve. On the vertical axis, there's cumulative mortality, and on the horizontal axis is time after randomization. And the reason I ask people to look at this is that you see there's separation early, before the first 100 days, with the treatment group having less mortality events than the control group. And by 12 months, you see an absolute risk reduction of 21%. It's important to understand the absolute risk reduction is how we determine the numbers needed to treat. And what you know from these data is you need to treat 5 patients with non-invasive ventilation to prevent 1 death. And that is really clear in terms of how we're going to treat. And anybody who knows the acute fields will know that is around the same number of patients we need to treat in acute non-invasive ventilation to prevent 1 death. So this is really important data. So who should we do it? Well, I'm saying you should target severe stable COPD, and that's patients with hypercapnic respiratory failure with a PaCO2 of 52 millimeters of mercury and FEV1 less than 1 liter. They're going to have a preserved exercise capacity, or relatively preserved, and a low exacerbation rate, a low annual admission rate. So these are relatively stable folk with COPD. And this is the types of patients, I would say, if you're looking at a chronic stable population, that should be targeted in terms of home non-invasive ventilation. So that's a very particular cohort of COPD patients. But now I really want to discuss the patients who have got post-acute COPD. These are the patients who are coming into hospital with an exacerbation of COPD. The exacerbation of COPD is life-threatening, causing acute respiratory failure. We treat them with acute non-invasive ventilation. And indeed, acute non-invasive ventilation is important because it improves survival and indeed saves the patient's life. But then the patients are followed up afterwards, and it's identifying if non-invasive ventilation in the post-acute phase has any benefit. And again, I want to use the whole idea of the PICO approach. Again, we're going to answer who, when, how, and why, but we're going to make sure that we use the targeting population, or what's the population we're going to target, the intervention, the comparator group, and then the outcome, which we will focus on the primary outcome, as well as some of the secondary outcomes from this study. Now, again, I'm going to go back to the acute environment, and we all know this very well, that using acute non-invasive ventilation has a strong evidence base. I said earlier that the numbers needed to treat using the chronic stable patient was at 5. What you see is in terms of the acute NIV, the numbers needed to treat is 8. So you need to treat 8 patients with acute non-invasive ventilation in COPD to prevent 1 death. In fact, for intubation rate, the numbers needed to treat is 5. And this also reduces the hospital stay. Now, the important point of this and these data is that the mortality at 12 months is still incredibly high. You come in with an acute exacerbation of COPD, it's severe enough to require acute non-invasive ventilation because you've got hypercapnic acidotic respiratory failure, but your mortality at 12 months is still high and can be above 45%. So these are a high risk of failure in terms of survival group. So if we look at them post-exacerbation, it's really important to understand who's going to recover in terms of those patients coming through with reversible hypercapnia, those patients who have got persistent hypercapnia. And what we see is patients with persistent hypercapnia actually drive the mortality. So if you're a patient who comes in with an exacerbation of COPD, with hypercapnic acidosis requiring non-invasive ventilation, and after the episode, 2 to 3 weeks down the line, your hypercapnia is reversed, then you're a patient that has the same expectation of survival in terms of the length of time of survival as a patient who had a eucapnic exacerbation. This is really important to understand. So we have risk groups and very high risk groups of those patients that have received acute non-invasive ventilation. So we need to think about readmission and death. And this is part of the reasons we developed a research program, which was readmission prevention in COPD. And indeed, targeting persistent hypercapnic respiratory failure post-acute non-invasive ventilation, we thought would be a significantly important target population. This was published back in 2017 in JAMA. And again, I'll highlight Dr. Patrick Murphy, who's the clinical lead here for the Lane Fox unit in London. So the HOT HMV trial, home oxygen therapy, home mechanical ventilation trial, again targeted patients who were hypercapnic. But these patients were hypercapnic at 2 to 4 weeks after an acute life-threatening exacerbation of COPD requiring acute non-invasive ventilation. Here is a graph of here's a table of the patients, and just for ease, I just want to highlight some important points because we're talking about who here. We are talking about patients with severe COPD. The mean FEV1 in this group was 600 mils, 0.6 per litre. These patients have a life-threatening exacerbation of COPD requiring acute NIV, and at 2 to 4 weeks after discharge from hospital, had persistent hypercapnic respiratory failure with a PaCO2 greater than 52 millimeters of mercury. They did not have any significant sleep disorder breathing, and they did not have significant comorbid obesity. So these weren't the OSA or COPD OSA overlap patients. These were COPD patients who'd had a severe life-threatening exacerbation, who'd received acute NIV, who at 2 to 4 weeks had persistent hypercapnia. Again, when you're examining clinical trials, you must look and be really, really cognizant of the fact of when you're looking at the consort diagram and why patients were included or not included in the study. And the importance here is we had a lot of patients who were excluded from this study. But in fact, if you look at a lot of acute trials, you'll see, especially within NICU, which is another trial area that we work, we have a number of patients who are not enrolled into these studies. And as you see, a significant proportion of these patients declined. But we had a significant proportion of the patients, and the majority of the patients, who failed to meet the inclusion or met the exclusion criteria. And just to look at that in a little bit more detail, you see here we divided these into groups, as you see, from unable to wean from non-invasive ventilation to patients that decompensated with oxygen therapy. But most importantly, we divided these up into understandably looking at patients as we were managing them in the hospital. And yes, 16% of patients declined. 11% of the patients were excluded because they had a high BMI with obstructive sleep apnea. Again, we didn't want the COPD OSA cohort. 22%, and I think this is really important, did not meet the inclusion criteria at 2 to 4 weeks. So it's really important to understand that we see patients that are hypercapnic in the hospital. We see them hypercapnic acidosis requiring acute NIV. They get through that episode. 1 in 5, the blood gases will return to normal by 2 to 4 weeks. A significant proportion of our patients were very, very sick and moving towards end of life care. And in fact, we discharged 16% of the patients on home non-invasive ventilation, because non-invasive ventilation could not be withdrawn without the patient becoming acidotic overnight. And so they were discharged. So this is a really important point as well about the patients we're dealing with within the hospital. So when we looked at the data overall, it was 50% of eligible patients who came for assessment at 2 to 4 weeks did not have persisting hypercapnic failure. Again, that's reassuring to me as a clinician that a significant proportion of the patients are actually going to recover in terms of hypercapnic respiratory failure. And in fact, feeding somebody into a clinic at 2 to 4 weeks will let you understand what their trajectory is in terms of whether they will benefit from home non-invasive ventilation or not. So this was a study where we used standard COPD treatment, as you saw with the chronic stable, and we use home non-invasive ventilation, home oxygen therapy. You'll see I've called it home oxygen therapy because these patients were unstable, and LTOT is only set up in the stable state of the patient. So hence why we called it home oxygen therapy rather than LTOT. Now we had a titration plan for these patients. Again, the whole idea of targeting a CO2 reduction. And we used a high pressure strategy. And again, for anybody who knows the field, what you'll know is that there's been lots of discussions about high pressure and high intensity non-invasive ventilation. And interestingly enough, when we've done studies and data around this, we show that the high pressure strategy is the reason that the carbon dioxide comes down. So it's really a matter of maintaining and developing and delivering non-invasive ventilation in terms of high pressure. But we had a standardized approach across all the centers in terms of managing the ventilation strategy. So again, it's always important to ask how. Well, in the home oxygen therapy group, the control group, they had 1 litre per minute oxygen. They had 1 litre per minute oxygen in the hot HMV group, but they had 24 centimetres water of IPAP, 4 centimetres water EPAP, and a backup rate of 14 in order to control or drive down the CO2. So here we are with the targeted reduction in CO2, and you saw 11 millimeter difference between the hot HMV and the hot treatment, which is a 17% reduction, which is actually in line with a chronic stable study that I showed you at the beginning from Thomas Kernlein. So the important things about clinical trial, you get the target population right, you get the intervention right, but what you have to show is the intervention is actually working. Because it could be in a clinical trial that the intervention is either not being delivered or the intervention is not working in terms of a clinical trial being successful and not in terms of the outcome for the patient. So again, this is all around targeted CO2 reduction. I think that's a common theme we see now in terms of managing patients with hypercapnic respiratory failure. So we had a home oxygen therapy in the control arm, the comparator arm, and then what we had as a primary endpoint was time to readmission or death. This was an event-related primary outcome. And what you see is the patients who received non-invasive ventilation, the hot HMV treatment, there was 4.3 months before they were readmitted or died. Whereas in the standard treatment arm, the control arm, you saw 1.4 months. So there was a significant difference between the treatment arm at 4.3 months and the control arm at 1.4 months. And what that really highlights to us, and this is the Kaplan-Meier, what you're looking at on the vertical axis is admission-free survival. You're either readmitted or the patient is dead. And so it's really important to understand within that readmission or death what the main drivers are. And I can tell you the main drivers will actually readmission rather than death within these groups. So hot HMV increased the time to readmission or death, but mainly readmission by 90 days. And hotter HMV reduced the likelihood of readmission by over 50%. This is a significant effect size. And so when you look at studies and you look at studies and say about the power of the study, the size of the study, it's really important that a study is multi-center because that accounts for a number of the biases that we see in our clinical studies and adjusts for those biases to make sure we've got the best study possible. But you do not have to have large numbers of patients when you have a large effect size. And again, when we look at the overall difference between the hot HMV group and the hot group, and you see that in terms of readmission or death, 63% of the hot HMV group were readmitted within 12 months, and 80% of the control group, the hot group, were readmitted within 12 months. So there is an absolute risk reduction there, and I demonstrate the absolute risk reduction on the previous study from Thomas Cohenline. And what you actually have to do is treat 6 patients with hot HMV to prevent 1 readmission or death. And I say readmission or death here, but from these data, I know the number of deaths was low within this 12 months. So it is around readmission. However, we can't stop readmission. And that is why there is still 63% of the treatment arm that are admitted within that 12-month period. It's just our primary outcome was time to readmission or death. So when you look at the secondary outcome, and it's important to understand mechanistically how we're impacting on the patient, because then we can tell the patient what we're aimed to achieve by the treatments we've got. And so the secondary outcome of time to first exacerbation, and again, this Kaplan-Meier highlights this beautifully, is that we've actually delayed the time to the first exacerbation. And we reduced the 12-month time to first exacerbation by 1/3. Now, this is really, really important. So we're delaying readmission because we're reducing the exacerbation. And so it's that primary event, which then leads to hospitalization, and the treatment with home non-invasive ventilation is reducing the exacerbation. When you look at the 28-day hospital readmission, this is very important for healthcare providers such as the UK and the US, and we're very focused on 28-day readmission being a marker of healthcare success. Well, it's not a marker of healthcare success, it's a marker of how severe the patient is in terms of the COPD, but we are driven by these financial incentives that we're given to make sure that we keep people out of hospital greater than 28 days, because 28-day readmission is seen as a treatment failure from the admission. And what you see here from the Kaplan-Meier, again, we're looking at admission-free survival. And what you're seeing between the blue and the red lines is a significant difference in terms of the treatment arm compared to the control arm. And with the patients that received treatment, they reduced their 28-day readmission risk by 2/3. So receiving hot HMV treatment reduces readmission by 2/3. So a significant success. We reduced readmission over the 12 or the time to readmission, and we pushed it out from 1.4 months to 4.3 months. We improved or increased the time to first exacerbation, and we reduced the 28-day readmission by 2/3. This is a successful treatment. So who should we target with home NIV to improve the outcome? Well, I think hopefully I've convinced you that we're going to take severe COPD patients who've had a life-threatening exacerbation of COPD, requiring NIV at 2 to 4 weeks. They have persistent hypercapnia. So, and for the PaCO2, their patients need to be persistently hypercapnic and obviously hypoxic. And then we can consider adding in home mechanical ventilation to home oxygen therapy with these patients. So why are we targeting CO2? And I think it's really important that we really stress how important it is to target the CO2 in these severely ill patients that we're managing with COPD. So this is a Kaplan-Meier, and it's broken down in terms of the admission free survival categorized by CO2 at 6 weeks post-randomization. So we've randomized the patients and we've seen the patients at 6 weeks after randomization. We've then undertaken another arterial blood gas in order that we can monitor the patient. And what the importance is I've used 7 kilopascals here. So if you know that's 52 millimeters of mercury. It's just we're rather peculiar in the UK and still using kilopascals. So, but what we're saying here is if the patient comes through and you see them receiving hot HMV treatment and their CO2 is still 7 at 6 weeks, compared to the group had a high CO2 greater than 50 millimeters of mercury at 6 weeks, there is a significant difference on the time to readmission. And what that means to me as a clinician is that patients, if we say at 2 to 4 weeks, oh, you can receive non-invasive ventilation or hot HMV treatment, and that will improve in terms of your overall or push out and reduce your risk of readmission and reduce your risk of exacerbation and definitely reduce your risk of 28-day readmission. Well, patients may take a view that they don't want to start the treatment. However, at 6 weeks after randomization, what we saw is the high CO2 at that stage, you can still go on to treat in terms of those patients that are likely to benefit from this. So start it up to 8 to 10 weeks post-discharge following acute exacerbation, obviously for those folk who haven't been readmitted. So when we're thinking about this, and this is from the European Respiratory Society guidelines that we did on long-term home non-invasive ventilation in COPD, and we've got the who, when, how, and why. And what I want to do is really stress that we've got the stable patients and the post-acute patients. And in fact, it is the stable patients who are hypercapnic, who've got preserved exercise capacity and low annual emergency admissions, that you should consider starting on non-invasive ventilation and targeting a 50 to 20% reduction in their CO2. And that will reduce all-cause mortality. For the post-acute patients, you take patients with severe COPD again, who've had a life-threatening exacerbation, who remain persistently hypercapnic at 2 to 4 weeks, again targeting a 15 to 20% reduction in CO2, and you'll increase the admission-free survival. You push out the time to readmission for the patient. So really, really important that we identify these particular phenotypes of COPD patient. So in terms of patient selection, what happens if you select the wrong patient? And this was really highlighted from the rescue study. And again, and those who know the literature, this was published by Peter Vextra in Thorax. And the rescue study took patients with moderate levels of CO2. And in fact, they set up the home non-invasive ventilation at the tail end of an acute exacerbation while the patient was still in hospital. But you see here, there was a significant difference between the CO2 in their study and the target compared to the study for hot HMV. And then we made sure with the hot HMV, they were persistently hypercapnic. And interestingly enough, in the rescue study, they had patients with potentially reversible hypercapnia, and therefore the prognosis would have been better for that patient. And the trial showed a reduction in both the PaCO2 in the control group as well as the treatment group. And there was no difference between the patients in terms of admission-free survival. So really important, 2 studies that came out at similar times that had different answers, but really, really helpful in terms of who are the patients we need to target to improve the outcome from their COPD and respiratory failure. So when we put the pieces of the puzzle together, we say treatment with home non-invasive ventilation, targeted reduction in CO2, targeted and that reduction in exacerbation frequency. I haven't shown the data, but the quality of life is enhanced, and that was shown in the hot HMV trial, as well as the trial from Thomas Kernlein from Germany in the stable group. Interesting enough, in the hot HMV study, we saw an improvement at 6 weeks, but we didn't see improvement thereafter. But we did see that the patients were using their ventilator, and by 12 months, they're using their ventilator for up to 8 hours a night. So there was a gradual increase in the adherence to non-invasive ventilation over that 12-month period. And obviously we saw a reduction in readmission. And when I said for the primary study, we didn't see a reduction in mortality, the actual per protocol analysis shows the reduction in mortality. And just to remind everybody, the per protocol analysis is actually those who got given the treatment and used it. As you know, intention to treat is we just give a treatment, and it's if you use it or not, we still count you in the final analysis. Whereas with a per protocol, if you're using it for more than 4 hours a night, you're included, and we showed a mortality benefit. So if you've got a treatment that shows clinical efficacy, then is it cost effective? And I think that's really important for us to understand with any treatment. And these data really highlight that within the hot HMV study. And what we see here is obviously between the treatment group, which were ventilator, to the control group, which was used home oxygen therapy, there's obviously more costs because you're providing a ventilator. The total exacerbation costs were less in the intervention group, and the total patient reported costs were significantly less in the intervention group. So we got a ventilator that costs more, and that adds to the cost in terms of device costs, but reduction in exacerbation costs and a reduction in total patient reported costs. When you see this, you see obviously there's an adverse position in terms of the device costs, but a favorable position for the exacerbation costs and a favorable position for the patient reported costs. And as I've highlighted to you, although we didn't stop admissions to hospital, there was a significant difference at 12 months, with 63% of those in the hot HMV arm being admitted to hospital, but 80% in the hot arm being admitted to hospital. So obviously there's a difference in terms of the admission costs, and you can see that from these 12 months costs, as I highlight here. So breaking this down, and as you know, for the UK, the National Institutes of Clinical Excellence drives and gives us the whole idea of making sure we have a cost per QALY. And in fact, the cost per QALY of using this, despite the adverse total costs, you see here is £10,360 a year, which is absolutely within the threshold for NICE, and indeed NICE will fund up to £30,000 a year. But if you're in the last year of life, NICE will fund up to £50,000. So this is well within the limits of NICE in terms of the cost per QALY and the cost effectiveness of a treatment. So cost effectiveness, hot HMV is a cost effective as well as a clinically effective treatment. And if we look at the cost effective planes, and those of you who are not so familiar in using these, on the upper panel, patients will be more expensive. On the lower panel, patients will be less expensive. On the left, the treatment is less effective, and on the right, the treatment is more effective. What we see with common treatments now, when we look at them, new treatments and novel treatments coming through where that red dot is, we tend to see those treatments that are cost effective on the border between the upper and lower panel, the less expensive or more expensive. But this is obviously a more effective treatment. And so really important to highlight this when you're looking at cost effectiveness. So home non-invasive ventilation in COPD. Well, it's clinically effective, and really important, it's clinically effective both in the chronic stable state and also in patients who are post-acute exacerbation. It's cost effective. We've shown on a cost per QALY using a UK model that it's £10,360, which is well within the NICE guidance in terms of cost per QALY. I'd like to thank you all for listening. I will take any questions coming from this webinar today. But importantly, I'd like to thank everybody who's involved in all the clinical trials we've been involved in over many years, and also the Centre for Human and Applied Physiological Science at King's College London, and obviously the Lane Fox Clinical Respiratory Physiology Research Centre. Thank you for listening. I'd like to hand back to my dear friend, Dr. Sue.
Thank you very much indeed, Nick. And I have to say, every time I hear those data, I'm reminded how impactful they are and how relevant they are to our clinical practice. So thank you very much. Before we take questions, I'd like to and there are many really good ones actually, Nick. I'd like to remind delegates about how they can obtain their educational credits for this activity. It's approved for 1 contact hour, so nurses and respiratory therapists can obtain their CE credits via this website, www.saxtesting.com, and you'll need to register at the site, complete the evaluation, and as we've said earlier, the support for this educational activity is provided by Philips. An archive on-demand version will be available on betteroutcomes.org, and I think, Greg Smith, I hope that answers your question. And the on-demand version will be accredited for nurses and respiratory therapists. Greg asked, will this be available for replay for other staff in my company? So I think, Nick, look, I always have loads of questions about these data because, as I say, they're so relevant, but in fact there are a huge number of really excellent questions that colleagues have asked. And if I could start with the first, which I answered in the chat, but I think it'll be helpful, Nick, for you to give an overview of the PICO. What does PICO stand for? It's much more than just an acronym, isn't it? It's the approach we take.
So PICO is really important, everybody, and I think those working in clinical trials, it's really the gestalt for how we design a clinical trial and the basis. So it's the P, the target population. It's who we are targeting, because that for me turns out to be the patient I'm going to treat with a treatment at the end. So it has to be really important we get that right. The I is the intervention. Now, in this case, we see non-invasive ventilation at the intervention. But just let's extend that intervention thought further, because what you have to show is the intervention works, because you can make sure that you say that an intervention, it's either failure to deliver the intervention or failure of the intervention. And so that's why I'm really keen when we're targeting CO2 that we make sure within COPD patients, we see from the eye, we see a reduction in CO2. So we've got the target population, we've got the intervention. Now the C is the easy bit, it's the control, it's the comparator. But in clinical trials, anyone in the control group is getting top rate clinical care. They're part of a clinical trial. So I always feel any patient involved in a clinical trial is better getting a more enhanced or advanced care over and above what they might normally receive clinically, because they get access to the clinical trial team whenever they require it. The O is really important. It's what ESIC, you and I sit down and talk about quite a lot in a number of our trials, because we know how much pressure there is to get the O right. The primary outcome is what has to be relevant to the patient, to the clinician, to the healthcare provider all at once. And that is really, really difficult. So the way we approached it, if I look at hot HMV, well, if I said admission-free survival, time to readmission or death, that's really important to the patient. And in fact, it's really important to healthcare. And as a clinician, it's really important. If I can have patients who are not in hospital or delay the time coming to hospital, then that is exceptionally important in terms of when I'm discussing with patients why they should use a treatment. The other reason is, and why we like to use admission-free survival, is that when you come to do cost analysis and you see a difference, The admissions cost all the money. The exacerbations cost all the money. So if we can reduce exacerbations, as we've shown in hot HMV, and we can reduce admissions to hospital or delay them, but also reduce them, as you saw from the data, then we're doing a good thing for both the patient, us as clinicians, but also for the healthcare provider, because we're making a treatment cost effective.
Thank you. That's a brilliant description of actually what is a very simple acronym, PICO: the right patient, the right intervention, the right comparator, and importantly, the right clinical outcome to study. Thank you very much. I hope that answers your question. There was another. I mean, there were some excellent questions. There's a further question from Monty Reed. Did you consider volume targeted NIV rather than high pressure?
So that's a really important question, Monty. And in fact, we wanted to make this as simple as possible. So anybody who's got the time and to go and look at the manuscript will see that we use two different machines, and we adjusted by site. So some centres had one machine, other centres had the other machine. But we use the ResMed VPAP STA, which is a very low-end type machine that we would use, and also the Philips Synchrony. This is nothing about the machines. They're obviously really very good machines, but we use pressure support. We use pressure support with oxygen entrained at 1 litre per minute. We're using an IPAP of 24, an EPAP of 4, and a backup rate which was only 14. So we were just trying to make this as easy as possible. Within the US and the UK, there's slight differences, and I know there's differences in the nomenclature for the machines that you use and whether it's got a backup rate or it hasn't got a backup rate. But within COPD, and we've done some studies where we've taken away the backup rate on folk, and we can actually see you get control of ventilation because the drive to breathe in COPD is there. So I'm not quite convinced, and it's worthy of a discussion perhaps from the audience, that you need to have a backup rate within COPD. We do, and we do that out of safety reasons. But if you were really going to ask me, could we make this and drive it into something much cheaper and even more cost effective because you're using simpler devices, then yes, I think we can.
Nick, I mean, it's very much the case that these patients have very high drive, and the point you made, regardless of the mode, is driving that CO2 down, isn't it, as a substrate for intervention. So I hope that answers your question, Monty. There are more questions coming in. So from Christine Hurt, this is something you went over, but again, it's a simple acronym, but really important. What does HOT stand for, and what is it? And I think to outline what's different.
Thanks, Isik, and Christine. It is really important because and it's important in the fact that home oxygen therapy, HOT, because in this study we were taking patients with acute exacerbations of COPD, life-threatening exacerbations who are requiring acute non-invasive ventilation. Now, some of them required oxygen to go home with, some of them didn't. But when the patients, if they went home with the oxygen therapy, or we were seeing them at 2 to 4 weeks, we couldn't call that LTOT. LTOT is very particular in the diagnosis or the definition, and you have to have 2 blood gases which are 3 to 4 weeks apart in a clinically stable state to actually diagnose someone with hypoxic respiratory failure. We were in an unstable period where the patient's oxygen may have got better, may have got worse, may have not changed. Definitely what we saw was improvement in arterial blood gases with oxygen going up and carbon dioxide going down over that 2 to 4 weeks. And so really important that we didn't call this anything but home oxygen therapy. Some patients went on to have necessarily, we could define them as LTOT, but it was really important that early stage, and hence why we just came up with the acronym home oxygen therapy, home mechanical ventilation, hot HMV.
Thanks, Nick. And a further question, how many hours were they on NIV for the study per night? Really important question about adherence.
And again, for those who have time to go and look at the manuscript, what you'll see is by 6 weeks, they're using it 4 hours a night. By 12 months, they're using it 8 hours a night. So these are patients that are improving in terms of their utilization. And we have to remember, and I think it was Brenda that asked this question, you have to remember that the patients are really severely ill. And over that 12 months, these patients are not getting better. And in fact, they're clinically deteriorating because that's the way COPD is. Um, but to see the patients then become more adherent to treatment, um, even though we only saw the differences in health-related quality of life at 6 weeks, we didn't see them at 3 months, 6 months, and 12 months. We thought to ourselves, is that due to the insensitivity of what we're using in terms of the SRI, which hasn't been validated in the post-acute phase, or the other health-related quality of life markers we were using? Because patients wouldn't use a technology, wouldn't use a machine, wouldn't use a complex intervention if they didn't feel it was doing them some good. And I think that's really important that we don't necessarily pick up all of these changes, because we know when we're sitting in clinic and asking the patients say they feel better. Now, how they describe better when you give them a questionnaire may be lost.
I think that's right, isn't it? We give patients this airtight mask that fits on the face. They have to see and feel a benefit in order to use it. I've got a further question. What types of NIV BiPAP? And I think you broadly answered that in terms of the mode, but it was a pressure support mode, wasn't it, Nick?
Yeah, so and going back to David, we used a pressure support ventilation. We wanted to make this simple. We didn't want to make it complex. I know we got into discussions about all those different types of mode, and we've done a number of studies now looking at advanced ventilatory modes. But this is a big problem. Patients are coming through the exacerbations of COPD and require acute non-invasive ventilation. And we felt that this needed to be done in a really thoughtful and considered way in terms of the, you know, the lowest type of technology that we have available. And again, it's not to any detriment to the technology we're using. We just wanted to make it as cheap as possible.
And as simple for the patient and clinicians as well across several sites, no doubt. Another excellent question, and I know this is something that you and I talk about often. What types of interfaces were used and which had better success rates?
So
this is one for the respiratory therapy.
That's a great question, and the reason that's a great question is we use full face mask, and we tend to use full face mask. And then you're going to say, "Oh, Nick, haven't you just done a meta-analysis, systematic review on purpose in thorax, saying the non-invasive or the nasal masks are as good as well?" I think this is all down to patient preference. We tend to use this in terms of the full face mask, so we can actually get the pressure delivered to the patient. If you went back 25 years when the real experts were doing non-invasive ventilation on the COPD, they were using nasal interfaces. They were using nasal masks. It's just that as the pressures have gone up, rather than the intensity, again, we've used full face masks. But I think that's area that we need to do more work in.
Yeah, absolutely, and it's one of the key areas for failure and success, isn't it? And the questions keep coming in, Nick. Thank you for the review. Why do you think preserved 6-minute walk test is relevant in the Kernline study?
So I think it's mainly because I don't know. I don't know these patients, Isaac. That's why I highlight the Kernline study. And I look at these data and the patients we see, because we're in a city, busy place where patients are coming with exacerbations the whole time, and we live in a socially deprived area in terms of the hospital, and so we've got a particular cohort. This isn't necessarily a cohort of COPD patients that we see within our treatment, but it's really important to highlight because they do exist. There's a randomized control trial that recruited them. It's just that they may be in different parts of the world, in different areas, and it may be more rural than urban. I don't know that per se, but we just need to be open-minded of when we're thinking about stable chronic patients, who are the ones that are most likely to benefit, and they're the ones with an FEV1 less than a litre, a relatively preserved walking distance. They've obviously got hypercapnic respiratory failure, and I just want to, with a low exacerbation frequency, and so I think it's just really important to highlight when you're looking at the data. It's not just saying, oh, they got stable COPD.
And I think that's right. As you know, I do these clinics where we follow these patients up kind of 2 to 6 weeks after exacerbations, and the vast majority of our South London patients are the post-exacerbation rather than a stable Kern-line cohort. I'd love to talk about this further, but we have so many questions. With regard to cost, is the NIV cost in the control group referring to the cost of in-hospital NIV used during exacerbations, or in the control group? NIV cost
this is
in
a
control
really
group refers to the cost of NIV.
yeah. So so the costs when you came into hospital, we have a fixed cost for those patients coming in terms of they get a bed day cost based on the acuity of their illness. So it doesn't matter whether they come in, it's their NIV machine or somebody else's NIV machine, as in the hospitals, everybody will have the same cost associated with that admission. The importance within this patient group, and what we thought with our hypothesis was, we didn't think we were going to affect exacerbations. We thought we would just have patients exacerbating at home, but because they had their own high dependency unit, they wouldn't come into hospital. But in fact, as you saw, we reduced exacerbation frequency in the treatment group. And in fact, everybody, or folk may be aware of the biology data of, reducing CO2, and it improves the ability to be able to kill off Pseudomonas and other bugs through interferon. So there's some biology that's out there that really is shown to be affected by hypercapnic respiratory failure. But as regard cost, once you come into hospital requiring non-invasive ventilation, doesn't matter whether you were part of the trial and you came in with it, or you got given it while you're in hospital, it's the same cost.
Fantastic. And further question, is the NIV treatment at night or during exacerbations? And I think it's both, really, isn't it? And exactly as you've alluded, I think the intention, if I might answer this one, is to use it overnight. But it's particularly useful, I think, during exacerbations, and it reduces, it elevates the threshold for admission. Would that be the approach you took, Nick?
Absolutely, and I think I completely agree with you that patients were using majority of the non-invasive ventilator at night. Why? Because you get nocturnal hyperventilation. That's when your CO2 goes up. So they're defending against that CO2, that targeted CO2 reduction. They're also using it during the day.
Absolutely.
And we've had data as early, as you know, about as patients are drawing towards end of life, we see the adherence to non-invasive ventilation go up significantly. So we talk about telemonitoring, and what we actually see is non-invasive ventilation going up and up and up to 16, 17 hours a day of non-invasive ventilation, COPD locked.
Thank you very much, Nick. Now, we do have a number of other questions, but we're actually, unfortunately, it's time to draw to a close with 2 minutes left to the hour. Once again, Nick, thank you so much for such an enlightening talk. My apologies to those whose questions we've not been able to answer, and I'd like to hand back over to Monica for her concluding remarks. Thank you very much.
Thank you both so much, and this does conclude our webinar for today. I would like to remind the audience that there is a survey for you at the conclusion that will pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. We thank you again, and on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, we hope you enjoy the rest of your day.
Thanks, everybody.